My name is Thomas Heldt. I'm with the Institute for Medical Engineering and Science and also with the Department of Electrical Engineering and Computer Science at MIT. My group is very interested in data analysis as it relates to critical care or intensive care units where a lot of data is being collected from patients who are critically ill. That data contains a lot of information about the state of the patient, about the severity of the condition that the patient is in, and also potentially about the future course of hospital stay of this particular patient, meaning that it could ultimately be used to predict what might actually be happening to the patient with given interventions. In a critical care unit, a lot of data is being collected from a patient. Some of this data comes at a very high temporal resolution, meaning that these could be the electrocardiogram, it could be arterial blood pressure, it could be a pulse plethysmogram. These are usually recorded at about 100 samples per second. So there, a lot of data is coming through these channels. Then there are medications that are given occasionally to the patient. Then there are lab results that are being reported on, for example, through blood draws. They might come once or twice a day. So physicians coming into an environment like this are faced with the fact that they actually have to screen a lot of data, synthesize that data in their heads, and on the basis of the information that they receive, come up with diagnostic decisions and treatment plans. Our interest really lies on the very high resolution of that data, meaning the waveforms like the electrocardiogram, blood pressure, cerebral blood flow velocities, and relate those data streams that are displayed on the monitor for the clinician to actually look at, relate these to actually models of the underlying physiology, meaning we can actually build mathematical models of what we think the physiology is based on our knowledge of physiology over many, many, many years, and then relate that data with the models to understand, to identify parameters of these models and understand better what might actually be going on with a particular organ system. So what we're really striving at is to provide the physician with a more complete picture of what might be going on with the patient. There are some measurements that the clinician ideally would like to have access to that cannot be made simply because it would be too difficult, too costly, or too dangerous to make a measurement, a particular measurement in a patient. But we might actually be able to estimate these parameters that cannot easily be measured or that can only be very costly be measured from signal streams that are already available, that are already being measured, if we actually understand the underlying physiology. And the codification of the underlying physiology is through mathematical models. So there's really two big categories that we're interested in. One is really to leverage the data that's being collected to provide the clinician with even more information. The other branch relates to clinical decision support, meaning that a lot of things that are going on inside of the clinician's head, to what extent can we actually have machines actually do these decision processes? Clinicians are very good in synthesizing information, and they're actually very, very good in discarding information that they think is not relevant, and really holding on to some key pieces of information that are really important. That has traditionally been very difficult to actually have a machine or teach a machine to do that. So our work, although we do some work in clinical decision support, is really focusing more on the first part that I've explained, which is taking all of the data, signals that we can actually collect at the patient's bedside, and understanding the underlying physiology through mathematical modeling better than by just looking at the raw data that are being displayed at the patient's bedside.